Hi, I'm Kerry, and the title of my PhD project is Developing Participant-Informed Methods for Acceptable and Safe Research into Suicidal Experiences. And I'm being supervised by Professor Sarah Peters, who you've just met, alongside Dr. Trish Gooding and Dr. Anya Witkowski. So just to give you an overview of what I'd like to talk to you about today, I will first give you an overview of my PhD project and its aim, and the studies that I'm carrying out as part of that. I want to briefly summarise the findings from systematic review that we're just nearing completion with, and how that links into the empirical work that's ongoing. And then today, I just want to focus a little bit more in more detail on a qualitative interview study that I'm conducting with healthcare professionals, and at the stage of working through the analysis on that. So some emerging findings to talk to you about today. So the overall aim of my thesis is to inform ethical design and conduct in suicide-focused research. And I am focused on perinatal population, so that would include women who are pregnant and up to 12 months following the birth of a baby. There are 3 studies, so the systematic review study, a perinatal cognitive interview and survey study with which I'm working directly with perinatal women, and the healthcare professional interview study, which is what I'd like to give you some more details about today. So in terms of the review, the research questions were: how do women perceive the process of being screened or assessed for mental health problems in the perinatal period, and which aspects of that process are most salient? It's a qualitative metasynthesis, and that's synthesised findings from 36 papers, and included more than 1,000 individual participants across those studies. The samples were drawn from a wide range of countries across the world, and quite diverse communities, which is a benefit. So in terms of the findings of this review, just to give you an overview, the analysis, we identified 3 interrelated constructs, and we called those opportunities presented by screening, difficulties with screening, and context and constraints. And each of those has several concepts which describes them in more detail. Now, the construct of context and constraints, now this represented the factors that sort of seem to impact the experience of screening, of mental health screening, and the likelihood of participants experiencing the process as being one that had opportunities or one that presented a lot of difficulties. And what we found was that maternity healthcare professionals, so midwives and health visitors, really are quite influential in influencing those external factors. And you see the box on the right-hand side does give some more a breakdown of how that can occur. So by engendering trusting relationships with the people they work with, by providing a safe and private space, by providing information and helping people to feel prepared for mental health screening, and by delivering the screening by whichever method's been chosen, by providing feedback, and by giving an element of flexibility and choice. And those were all factors that were found to be quite important to the people within the studies. So in terms of suicidal experiences, so not all studies, with the exception of one, did focus only on talking about suicide. Those that looked across at just general mental health screening, there was still a lot of data around talking about suicide and being asked about suicide. And what we found was that the positive and negative aspects of that experience also applied to disclosing suicide potentially. And so the positive aspects were things like, feeling a sense of insight and recognition and feeling very validated by being asked. But also the negative side, a fear of disclosure because of potential consequences, feeling stigmatized, or even being judged to be an unfit parent. Overall, there was also a general feeling sometimes that healthcare professionals were preoccupied with assessing risk, and that screening could feel quite a narrow process in, for example, only focusing on postnatal depression. And that didn't leave a lot of space for the disclosure of suicidal thoughts or feelings, which, as we know, can be quite nuanced and, incorporate quite a broad spectrum of experiences. So NICE in the UK do recommend that healthcare professionals focus on areas that could present possible risk, and that does include suicidal thoughts and intent. But they offer suggestions for depression case finding questions, anxiety case finding questions, but no specific guidance on asking about suicide in the perinatal period. The longer screening tools, such as the EPDS for depression and PHQ-9, do have a single item that asks about suicidal ideation, but that's not necessarily conducted on a regular basis in routine practice. So there's currently no maternity or suicide specific tool used in frontline services. So the rationale for this qualitative study then was, well, midwives and health visitors are that primary point of contact at this time and can actually be gatekeepers to research participation for women. So we need to understand their views of discussing suicidal experiences and what the facilitators and barriers might be, and whether or not these converge or depart from women's views. So the research questions were to explore midwives and health visitors' views of discussing suicide with the women in their care and the use of suicide questionnaire measures in the perinatal period. And the methods, as I've described already, qualitative interview, which was semi-structured, looking at these various aspects of the phenomenon, and also asking them to have a look at a number of brief suicide measures. And I'm using a reflexive thematic analysis approach to the analysis for this. So this is a list of the brief measures that I did ask the healthcare professionals to have a look at on the left. And on the right-hand side, you can see some of the examples of the questions that are contained within those measures. And we wanted to get thoughts about those and potential use for them. So we had 15 healthcare professionals take part in the study overall, mainly from the midwifery profession, but we did also have health visiting professionals and those who were dual practicing. Generally, most general roles, but some specialisms as well. 80% had more than 6 years experience, and we had those from final year students up to people nearing retirement with a good spread of age groups. And they were primarily white British, but we did have thankfully, some diversity in the sample. So just to give you a quick overview of some of the themes that are sort of starting to come to light looking at the data. The word right was used a lot across the interviews. Participants talked about saying the right thing, asking at the right time, referring to the right person, getting the right source of support. And I just think that it really conveyed that sort of deep sense of responsibility that was felt around addressing a sensitive topic such as suicide. And, how there was an element of trepidation about getting things wrong, and there was really a right way to do things. Participants brought a lot of their personal views and experiences they may have had on a personal level with mental health and suicide. And you could see how that was, playing a part in informing their views about suicide prevention and how they, as a healthcare professional, had a role to play in that. Those who had had previous experience of caring for someone who was suicidal said they felt confident in future to support somebody who disclosed that and were motivated to ask the question. Conversely, people who had not reported having an experience did often feel an element of worry about asking if someone had suicidal experiences, even that perhaps it could offend that person and damage the relationship they were building with them. With confidence, clinical judgment came into play, and some participants said that they felt confident to know when to ask or how to ask a question, and if somebody disclosed, how to assess the urgency of a situation. And that was helped if they already knew the person had sort of an element of a relationship with them. There was definitely a distinction between supportive and, I'd say, procedural talk. So some participants felt they had a holding space for disclosures. They could offer emotional support. And others were more focused on talking about taking action. So who they would refer to, the processes they needed to follow. And some actually said they just didn't feel equipped to provide mental health support to someone who may express feeling suicidal. In terms of the research participation in this group, our participants felt that it was a positive thing that women took part in suicide research and talked about there being benefits to that. But they were keen to stress that it was important to them that they felt the person had stable mental health at that time, that the person felt safe, and they trusted the person who was asking them to take part in research. There were several barriers and facilitators talked about in terms of having conversations with women. Continuity was consistently stressed as something that was key. So the same person caring for somebody throughout their either pregnancy or postnatally. They felt that if continuity was lacking, it was a real barrier to feeling able to ask a question about suicide and for women to feel comfortable to disclose to them. Knowledge was another factor. Training support was said to be lacking when it came to mental health and specifically when it came to talking about suicide. Having professional support, so informal and informally, so knowing that there was somewhere to go for advice and there was specialist knowledge available to them was really important. And it seemed to sort of relieve that burden that the person might feel professionally responsible for keeping the person safe, the person in front of them safe. And so having that whole team approach was really important. Time and space, that was unanimous in being sort of cited as one of the biggest barriers to asking questions about suicide. And, people sort of expressed a feeling of not wanting to open a can of worms should they disclose and having no capacity to address that person's suffering. So that was really important also. When I asked participants to look at the questionnaire measures, most felt a specific tool about suicide would be really useful in practice, that it could even help increase awareness and break taboos down. But they did have different ideas on when would be an appropriate time or setting to ask those sorts of questions. There were conflicting views on whether we should be screening universally in maternity for suicidal experiences or whether we should take a more targeted approach to ask questions to a subset of people. But overall, there was definitely a view expressed that training is needed and support to implement any routine questions that might be introduced in practice or, in research settings. So in terms of that's just a quick overview of where we are with the analysis at the moment. So next steps for me are to continue with the analysis and to finalise those themes. The data collection is ongoing with the perinatal participants and with the ultimate aim, bringing all these findings together and hopefully to inform communication about suicide in this population, both in a clinical and research setting. Thank you for listening, and I'd like to take the opportunity to really thank Mental Health Research UK for their continued support during my PhD and, of course, my supervisors. Thanks very much.